Hello, everybody. Welcome to Pediatric Grand Rounds. Today is a special Pediatric Grand Rounds because we're looking forward to hearing from some of our residents on their quality improvement projects that they've been working on. And who's gonna run the session? Jocelyn. Okay, I'm gonna hand it off to you.
Like I was saying, it's so nice to be here in person, to see you guys and present in person. It's been everything over Zoom for so long. That's really, really mask off. Yes, better. Great. I can't get used to that either. I'm really excited here to be here to talk to you today about our quality improvement projects in our resident clinic. And I just want to acknowledge what a privilege it is to have the space and the time to really dedicate to thinking about quality improvement, to really take the things we learn in our research and our time spent in inpatient, our time spent just thinking about this and really being able to funnel that into patient care, which is really what we're here about, is to really provide quality patient care. And so I really, again, want to acknowledge what a privilege it is to be able to do that in an institution like this. I wanted to run down quickly the name of the presenters we have here, because I think it's a lot of work and a lot of energy that they spent putting these slides together. So today we have Lisa Grossman, Maron Mashesha, Olivia Molyneux, and Justin Overall, Kelly Walters, and Rebecca Webb here representing all of their 5 clinic pods. Before we get started, I wanted to do the Elaine acknowledgement. I wanted to acknowledge that we are speaking to you from the traditional territory of the Ramaytush Ohlone people. As guests, we recognize that we benefit from living and working on their ancestral homeland. We wish to pay our respects by acknowledging the ancestors and relatives of the Ramaytush community and by affirming their sovereign rights as First Peoples. So I also wanted to let you know that we, as all the presenters, including myself, have nothing to disclose and no conflicts of interest. And then go over quickly our objectives for today. So today we wanted to illustrate how the staff, residents, and faculty can collaborate on a practice-wide quality improvement project while still learning the fundamental QI skills that we want the residents to learn and also the faculty to continue to hone. We want to discuss the health disparities in accessing medical information for our limited English proficiency patients and ultimately improve our MyChart activation for these patients. Just as a little summary or overview of our resident clinics, for those of you who aren't familiar with it or haven't been there before, we are located at Mount Zion. There are other residents who are at SHH, but this site we have 46 residents, and so there are 9 per pod, except one pod has 10 residents. There are usually 2 preceptors per day there. We have a third who generally rotates in and out, and then we have continuity clinic 5 days a week there, mostly in the afternoons. We also have obviously a large front desk, MA, LVN, RN, and administrator pool, as well as 3 social workers who are there helping. And then again, these are just some personal acknowledgements. We want to really acknowledge the Mount Zion faculty who really helped mentor and push along these projects. We have Dr. Suni Kaiser, who is the Director of Education for Quality and Safety, who's helped with this curriculum for the residents. And then these are all of the residents in all the pods listed under the resident physicians. And then again, all of the Mount Zion clinic staff and administrators who've really put a lot of effort into these projects as well. We don't have to read all of this, but this is just, again, a reminder of the quality improvement curriculum goals. So we really want the residents to learn about the lean methods and enhance our clinic or health system goals and really gain experience on applying these to real world clinic situations. And then just for some historical context around our quality improvement projects, we started this last year. So in the 2021-22 academic year, we moved from individual clinic pod projects to a more clinic-wide designated goal, which each pod picking and presenting different projects that they've chosen within that realm. Previous projects, including last year's project, was on developmental screening. We've had MyChart activation, general MyChart activation, not just for our limited English proficiency patients. Vaccination rates, including HPV, for example, food insecurity in one of the pods, resident wellness, parent coaching, a lot of other sort of aspects of primary care. And then again, we chose the topic we chose this year as a clinic was improving access for patients to limited English proficiency patients to their MyChart or kind of in general a patient portal. And I just wanted to go over again why we think this is important, why we chose this project. So we realized that kind of based on observations and studies that it's important for patients to have access to online portals because it helps facilitate patient and provider communication. It does help enable discovery of medical errors, patients reviewing their records, reviewing medications, reviewing other functions that they have within their portal can help present these errors to the providers and to the staff. And then accessing care, so accessing appointments, canceling appointments, changing appointments is a really huge feature. And then improving adherence to medications is also something that we've found has been helpful with the use of patient portals. There have been some studies looking, one study specifically where this quote comes from, looked at a specialty clinic and assessed that patients portal users had higher knowledge about their disease, higher rates of current health, and lower disease-related stress. And we know that all our limited English proficiency patients have difficulty with all of these other problems, not just accessing MyChart, but just in general have issues with access compared to our English speaking or English preferring patients. And so helping improve their access to the portal, not only by having them register for a portal and using a portal, but also improving their the language flexibility of the portals is hugely important. So now I'll pass it on to the residents from each pod to discuss a little bit more.
Okay, hopefully everybody could see me and hear me. So my name is Meron. I'll be going through our A3 format. It's basically a lean management tool, as Jocelyn said. And we'll start with the problem. So we'll go to the next slide, and I can put my volume up if it's a little low. Okay, perfect. There we go. next slide. Thank you. Basically, the problem identifies the background and importance of the context of why we chose this QI project, kind of similar to a lot of the things that Jocelyn mentioned. I appreciate that she mentioned some of our patch projects. One of them being the food insecurity one, because we kind of were able to identify gaps and provide solutions, which I think is something that we were able to do with this initiative as well. So there's a clear inequity in MyChart enrollment. I'll kind of go through some charts in a bit based on language. So Spanish speaking families compared to English speaking families. And as a result, there are inequities that can cause harm and worsen health disparities and outcomes. Jocelyn slightly touched upon as well. But here at Mount Zion, sorry, I think I'm on the problem slide. Then yes, there we go. Mount Zion Pediatrics should always aim to deliver more equitable care to our patients and actively work towards reducing and eliminating inequities, as well as subsequent health disparities. So I'm going to move on to the next topic of current state. So I know this is a pretty busy slide. I'll try to walk you through some of these charts. But to start with, this is a view of the UCSF Health MyChart Activation Equity Dashboard. It's a user-friendly tool created by UCSF Health Informatics Data Science and Innovation team. And this dashboard allows us to look at MyChart activation by language, which you can see in the left corner, age group in the right-hand corner, upper hand corner, race and ethnicity in the bottom left, and then financial class in the bottom right. And these are across all various locations, departments, specialties at UCSF. And the dashboard shows end-of-month snapshots of the percentage of MyChart activation and percentage of activation 2 weeks after the given clinical encounters of that month. So I'll start with the chart on the left upper hand corner, which was our focus, which is language and MyChart activation. As you can see, English speaking families are in the blue line, substantially higher than non-English speaking families, for example, Spanish speaking. The chart on the right with age, we didn't necessarily focus on age, but just to give you an idea of the different charts that that are able to be generated. And then another chart that's interesting is the chart on the left bottom corner, distributed by race and ethnicity. As you can see, kind of the overall lower curve is actually Black and African American, which would be an interesting thing to focus on in the future. Latinx also at the lower end, I think we're in blue. And then finally, on the right bottom screen, is financial class based on insurer. So you can see Medi-Cal is at the lower end of the curve and commercial is at the higher end of the curve. So I'll kind of go through some percentages on the next slide. So in October of 2022, primary English speaking families and their MyChart enrollment was 93.1% at the time of encounter. Combined limited English proficiency MyChart enrollment was 58.8 at the time of encounter, and primary Spanish speaking families were 48.6% at the time of encounter. So a huge discrepancy. And this is one of the main reasons we decided to focus on this as a clinic. So I'll go ahead and pass it on to Lisa.
Great. I'm going to talk a little bit about our target and the goals for the project. So the overarching goal of this QI project is really to increase the percentage of MyChart enrollment for Spanish-speaking families from 48.6% in October of 2022 to at least 60% and hopefully even 70% by March of 2023, thereby reducing the significant ongoing disparities in portal access between English-speaking and Spanish-speaking families. And I just want to comment briefly too on the choice of activation or enrollment as the outcome measure. So we really chose activation because it's the easiest to measure quantitatively and also because it's the most available measure of portal access, but activation does have limitations as a measure. It won't tell you about how often the patient uses the portal after activation. It won't tell you qualitatively how comfortable patients feel interacting with the portal, and it won't tell you about patients who were offered an opportunity to activate but were subsequently unable to due to some barrier. So although we're only measuring activation itself, we hope that our interventions will have had a broader impact both on the process of activation and also on the subsequent use of MyChart by Spanish-speaking families after activation.
So I'm Olivia. I'll talk a little bit about what we're thinking in terms of what the potential reasons are for along the way as people get towards being able to get MyChart activation. So we did this fishbone. We tried to identify a couple big categories where we might craft some interventions that could be useful. The first barrier that we identified is a sort of overarching family-specific barriers. Maybe they don't have access to compatible technology. Maybe there's a lack of awareness that MyChart exists and why it's useful. And then for clinic-specific barriers, there's not necessarily a time in your clinic flow where there's a good sort of designated time for MyChart access activation. There's lack of instructions on MyChart activation for the patients, especially in languages other than English. There's lack of screening. So there's not somebody in that clinic flow as someone's getting placed into their room who is responsible for identifying people who don't have MyChart access. And then just limits in time of the front desk staff and availability of Spanish-speaking front desk staff that can help troubleshoot with families who are Spanish-speaking. For resident barriers, a lot of times residents weren't feeling like they knew how to sign up families for MyChart themselves, although that's something that doctors can do. And there's a lack of awareness of which families didn't have access. It's part of the chart, but it's not something we were necessarily routinely checking. And then lack of time in the visit to encourage families to sign up. And then some residents were feeling that they got the message they weren't allowed to or weren't encouraged to enroll patients themselves. And then the last piece of this is just technology-specific barriers. There's lack of the availability of MyChart in many languages. It is now becoming available in Spanish in addition to English. But in addition, there's not sort of a lot of other languages that are covered by MyChart. And then the EMR doesn't consistently provide an option to sign parents up using their email or phone number if they're not already themselves a patient as part of the UCSF system. So what I really wanted to show here was that all the pods had a slightly different intervention. And the color coding here is in alignment with sort of where we hit where our intervention hit on this fishbone diagram. For many interventions, we're kind of tackling multiple different aspects of this. So I'm from Wednesday Pod. I will just use this as an example. Our intervention was, we're in yellow, was both addressing the lack of knowledge of how to sign families up for MyChart on the residents' behalf, and also part of our intervention was to address lack of awareness of which families were enrolled. So you'll see a lot of times the interventions that people will talk through in just a moment, we're kind of trying to address multiple parts of this fishbone diagram, and all together, our 5 interventions, hopefully, we're contributing as sort of a combined effort to our final results. So I will pass it along to Monday Pod. So we'll start with Meron and Kelly.
Thanks, Olivia, and hi everyone, I'm Kelly. So like Jocelyn and Olivia were saying, even though our entire clinic had the same shared goal to increase MyChart enrollment in non-English speaking patients, each pod or clinic day took ownership over the specific interventions that we wanted to implement. So our pod, Monday Pod, decided to have a resident-led effort to sign patients up. So we would actually sign patients up during our visits. And the reason we chose to do this is because we wanted our residents to be directly involved in our intervention, as opposed to kind of like having the front desk or somebody do it and lose sight of what we were doing. And we also wanted to empower residents to learn and be able to set patients up for MyCharts in other settings outside of the clinic setting. So we went through as a pod and kind of taught our co-residents how to locate where in someone's chart it says their MyChart status, and then how we're able to send them a text or an email to sign up during the visit if they weren't signed up already. Sometimes we ran into technical difficulties on our end where it said, we didn't meet the minimum requirements, or we didn't have security to grant access to families. And so in that case, we referred them to the front desk on their way out to help sign up for MyChart. We also wrenched in a preferred language tab, and we did try to make an effort to sign up all patients for MyChart, even English speaking patients too, but this helped us identify our non-English speaking patients in advance so we could be more intentional about completing that goal during the visit when we were trying to do lots of other things too during their visits. And if our patients weren't previously enrolled, we also asked them why they weren't on MyChart so we could kind of better tailor the next steps of our intervention. So we tracked this data all in a spreadsheet that we shared within our clinic pod, and we were able to elicit some reasons that patients who weren't on MyChart before had not been on. Some people reported that they had password issues trying to sign up. Some said that they were unable to link the parent chart with the patient's chart, so there was like no proxy identified connected to the patient. Some families also reported that they didn't really feel like there was a benefit to MyChart because there was a language barrier. In that case, we did let them know that there was written information, for example, the after visit summary in the patient's preferred language available on MyChart. And then that we also did have the ability to have our messages to and from our Spanish speaking patients translated within 1 to 2 business days, but that is currently only available for Spanish and not other non-English languages right now. Passing along to Lisa from Tuesday Pod.
All right. So in Tuesday Pod, our interventions were designed to address what we saw as 2 fundamental drivers of differential enrollment between English and Spanish speakers. And the first and most important is provider biases. So unfortunately, there's a lot of evidence in the portal literature that providers only talk about MyChart enrollment with patients that they perceive as tech savvy. And that is younger, whiter, richer, more educated patients. And this is a huge driver of inequity. And so our solution was to switch from an opt-in to an opt-out policy for discussing MyChart activation. That is, we made it a formal policy in our clinic to discuss MyChart activation with every single patient who we saw was not enrolled. We borrowed this idea from Jessica Anker and her colleagues, who showed that such universal access policies can greatly reduce disparities in both portal activation and use. And as part of this, we also created and shared a dot phrase with information about MyChart for patients, which can be found at .info MyChart. And we also updated our well-child check templates with reminders to discuss MyChart enrollment. The second problem that we were targeting is that some parts of the activation process with the front desk are English only, even though the portal itself is mostly available in Spanish. More on that later. So to that end, we translated the MyChart enrollment form offered by our front desk into Spanish so that Spanish-speaking families could complete the enrollment form in Spanish. Passing it off to Wednesday Pod and Olivia.
So for Wednesday Pod, I would say our strategy looks similar to Monday Pod in that we provided education to residents on how to perform MyChart activation and encourage them to have the patients seek help at the front desk if they weren't able to set this up, because as Kelly so beautifully demonstrated, sometimes you'll attempt to, and if you'll sometimes get sort of like a tech loop around when you attempt to sign up a patient. And then what we did is we went in a column that actually said, instead of the language preference, it said the MyChart status. So you can see here, I happen to have a panel of patients on the day I screenshotted this that were entirely activated, which would happen often. But you'd be able to identify when you had a patient who had not yet had their MyChart status activated. And then I'm not sure how other people in the pod did it, but I would sort of make myself a little checkbox in my little yellow sticky note that I use to make sure I'm keeping up on vaccines and everything. And I would say, hey, talk to this family about MyChart activation. So that was our general approach. And I'll pass it along to Thursday Pod.
Okay, so similar to Wednesday Pod, our group also added a MyChart activation status column to our clinic schedule. And then we also created some signage just talking about some of the benefits of MyChart and encouraging activation. These signs were placed in the Mount Zion primary care waiting rooms as well as the acute care waiting rooms. And then on this next slide, we just have a little bit of a close-up of what the form looks like. So in both English and Spanish, going through some of the specific benefits as far as allowing folks to communicate with their child's healthcare team, request refills, access test results, and manage appointments, similar to some of the benefits that Dr. Nolasco highlighted. And then we have at the bottom a QR code that links more easily to the online registration form for folks to sign up. Now, Friday Pod.
Hi, I'm Becca. I'm with Friday Pod. So for our pod, similarly to the prior pods, in terms of resident-specific barriers when discussing this issue and making our own fishbone diagram, the first step that we did was also in our PCP panel report, one, learning to generate reports, then two, having it show our activated or not activated MyChart status for all of our patients. So then that way we can kind of work through that as we saw our panel throughout the year. In terms of family-specific barriers, in thinking about limitations to accessing MyChart, internet, we talked a little bit about incorporating it into our workflow at the end of a clinic visit with a patient while we were sitting there one-on-one with them, potentially with an interpreter on the line if needed, so that we could sit there and help them through the activation process. And further taking that a step that is more physical and tangible in terms of printing out the MyChart activation section that is generated in the AVS and kind of circling, highlighting, showing exactly what is the link that needs to be inputted. So adjustment to flow. And then we also had discussions similar to Thursday Pod around signage, both in the clinic waiting rooms, to talk with families about this as they enter and are checking in with the front desk, as well as in our exam rooms as a reminder to the provider. Passing it back to Justin.
Okay, so moving on to the next section of the A3 model for QI is the study and follow-up. So for these next set of slides, we'll be using some specific definitions brought to us by the IHI. So a shift is when there are 6 or more consecutive data points looking at a run chart that lie on the same side as the lie on one side of the median. A trend is when there are 5 or more sequential data points that are all consecutively going up or all consecutively going down. And then an astronomical point is when there is one point that is very different from the others, so essentially an outlier. And so this chart here shows Spanish MyChart enrollment at the time of encounter. So as we highlighted earlier, the data available in the data dashboards is a snapshot for any given month in time, typically the end of that month. And the data, I believe, is published 2 weeks after that end of month period closes. And so pre-intervention, so I think for most pods, the intervention period kind of more concretely started in around November 2022, highlighted with the star here at the bottom of this graph. But pre-intervention, the median enrollment was 41%, and post-intervention, it was 53%. We don't see any specific data trends on this run chart. And so this chart shows Spanish MyChart enrollment 2 weeks following the encounter. And so pre-intervention, we see that the median enrollment was 45% and post was 63%. And so beginning in September is actually when we start to see that there's a positive shift above the median of percent of MyChart enrollment 2 weeks after the encounter for families who are primary Spanish speaking. And then if we're considering the kind of beginning of the initiation of our QI interventions in the pods, we see that that shift is maintained. And then also wanted to highlight a possible astronomical data point with the 96% enrollment for that given month in January 2023. And so one other thing that we thought would be helpful was to look at not only the kind of absolute percentage changes, but also percentages, but also the change in enrollment or the delta that happened between that given encounter and then the 2-week follow-up period. So for our Spanish-speaking patients, we see pre-intervention, the delta, so how many folks were, what percentage increased after that encounter? It was 4%. And then post intervention, the median increased to 12%. And so we can see kind of starting right around November with the initiation of the interventions is when we start to see a positive shift in the delta or change in percentage. And then also highlighting this astronomical data point of a delta of 37% that we saw in January of this year. And so we thought it would be important to also look at the change in English enrollment, most importantly to make sure that we weren't inadvertently widening any gaps or disparities in MyChart enrollment. And so for English MyChart enrollment at the time of encounter, pre-intervention was 92%, and then post-intervention went up to 94%. And we can see that beginning in August 2022, so much earlier in time before we initiated our QI interventions, we started to see this positive shift, and looks like that has been maintained throughout 2023. And then as far as the enrollment 2 weeks after the encounter, so again, as the group highlighted earlier, English participation and enrollment is in MyChart is by far the highest amongst UCSF as a whole, but also within UCSF Pediatrics at Mount Zion. And we start to see this positive shift starting quite early in 2022, and that has been sustained as well. And then finally, as far as the delta for English enrollment, there's actually no clear relationship or specific trend that's seen. So the pre-intervention delta and post were identical at 2%. And now passing it back over to Becca.
Okay, so what does all this mean? In conclusion, the median end of month MyChart enrollment at the time of encounter for families who are primarily Spanish speaking increased from 41 to 53% between the pre and post intervention period. Second, the mean end of month MyChart enrollment 2 weeks after an encounter for families who are primarily Spanish speaking increased from 45 to 65% between pre and post intervention. Third, the median change in MyChart enrollment before versus after the encounter for these families that were Spanish speaking was 4% during the pre-intervention period and 12% post-intervention. And lastly, Mount Zion Pediatrics is beginning to see a positive shift in MyChart enrollment for these Spanish-speaking families. For this slide, in terms of looking at the median end of month MyChart enrollment at the time of encounter for families who are primarily English speaking, this increased a little bit, modestly from 92 to 94%. Next, the median end of enrollment MyChart enrollment for 2 weeks after encounter for primarily English speaking families increased from 95 to 97%. And as Dr. Overall was just mentioning, there was no difference in the change in MyChart enrollment, our delta, at the time of versus after the encounter for families who are primary English speaking pre and post intervention. So in terms of thinking about this study and what our goal was in terms of activation of MyChart accounts in Spanish-speaking families, several considerations have been touched on already in terms of barriers, translation and interpretation of MyChart features, even in terms of just getting activated was a limitation. Further, in terms of thinking about the utility of this when patients or providers are not language concordant and sending and responding to these MyChart messages, I think that this could potentially be a limitation for kind of motivation for families to enroll. And then in thinking a little bit about the concepts of equity versus equality as it pertains to this QI project, is MyChart access something that families need or do they even want? Is this even helpful for them? And so I think in addressing that, further exploring these questions with families, whether that be through focus groups, phone calls, to figure out what aspects of MyChart are helpful for them, and or if they did not choose to enroll, what were some of the reasons for doing so? And so in terms of thinking about next steps, moving forward from this, I think that there's a lot. So I think that we all can agree here that yes, access to these portals for non-English speaking families is important. But in terms of actually advancing and serving as a proxy for health equity or health outcomes, we can't use it in that manner, given the paucity of research for pediatrics. And I think also thinking about kind of further refining this in terms of tracking or monitoring rates of health conditions, health disparities within UCSF. Definitely a wonderful and worthwhile endeavor in the future, as all QI work for the AP should focus on health equity and reducing health disparities. And so I think these are our references. And thank you all for your time, and to our faculty preceptors and wonderful patients. Thank you.
Okay, so I think now we have some time for questions. Go ahead, please, Sandrine.
Yes, I want to start by really applauding you for taking this on, and it's really such a great project. And I'm reminded of this quote by Margaret Mead, I believe, that says, "Never doubt that a small group of committed citizens can change the world, because really nothing else ever has." And I'm sure it sort of feels like a lot of work with a little bit of progress, but I think it's progress nonetheless. So I really want to applaud you guys for taking this on. And once again, pediatric residents show UCSF Health how to do their job. So thank you. That actually gets me to my question: is, do we know anything about use of MyChart across UCSF, like adult specialties? And have you at all connected with the UCSF Center for Health Equity or any other groups to talk about your findings and what you're doing? And I'm asking because, and I think you're getting at that in one of the last slides that you presented. I suspect, I don't know for sure, but I suspect that MyChart was designed by someone who looks like me, or maybe Dr. Hirsch, or right, whose English is their first language, and they're thinking about healthcare and healthcare needs is very much grounded in a white privileged stance. And I wonder actually whether it would be really useful to get some of our target population. And you want to do qualitative work, but actually make that a much bigger UCSF health focused thing to see what do people actually want or need from MyChart, rather than saying, here's what we think you need. Take it. Why are you not taking it? So,
did any of you guys? And I can speak a little bit to it. Do you want to? Right, go for it.
My understanding is that most of the monitoring of MyChart activation and use at UCSF is done by the, excuse me, Center for Clinical Informatics, which has just recently become a division, now the Division of Clinical Informatics, headed by Julia Adler-Milstein, which is a really fantastic resource for us here at UCSF, because Dr. Adler-Milstein is in fact responsible for monitoring MyChart use across the entire nation. And so it would, I think, be fabulous if we could connect with that team regarding MyChart activation and use. And then with regard to, of course, making changes within MyChart itself, it just is extremely difficult to make any sort of modifications within a vendor-controlled system like MyChart, as I'm sure all of you have been intimately familiar with. But there, I think, are new ways of doing that. More recently, with the advent of FHIR APIs, opportunities for integrating third-party applications within MyChart and MyChart enrollment process, in addition to integrating those types of applications into Epic. So I think that would be very interesting to pursue as well.
Yeah, I'll just add, like you had mentioned, this is a dashboard that we all have access to. You can look under UCSF dashboards, includes all clinics and all adult populations. Having looked at that in the past, it's very similar rates to our pediatric population, likely for very different reasons, but very similar disparities.
I want to echo what curious at those outliers, or that one astronomical and maybe apply if there were any factors there that could be applied from forward.
The short answer is we're not sure what contributed. I guess if we were to make an inference, I think that was probably a large peak of just like at least what I feel anecdotally, all of the clinic pods were really hands on deck as far as really being intentional about their intervention. So whether it was having those one-on-one conversations or really making the materials widely available for instructions for families to enroll, I think it was just kind of naturally a peak time of activity from all the individual interventions. And I will say one limitation that we didn't get to discuss is because there are so many wonderful things going on that we all were working on as individual clinic pods. It's hard to know exactly which interventions contributed the most or kind of what supported the enrollment the most. But I think to some of the final points, having more of that qualitative data that I know some of the pods were able to work on getting to identify both barriers and factors that help support enrollment.
I'll just add really quick as Olivia is coming up here, just with some inside knowledge of the clinic. That was a time when we had a big surge in visit volume. Is that what you're going to say? In visit volume, and a lot of difficulty accessing care. So I think there was also motivation for easier access for patients and again, respiratory surge. Exactly, respiratory surge, and along with the advocacy of all our residents and staff, signing up for MyChart became attractive as well.
I have nothing to add. Dr. Hirsch.
I have a question. First of all, that was great. Thank you. Great work, everybody. It was really encouraging to see how a relatively short-term intervention had a pretty dramatic positive effect. But a lot of times what happens with these quality improvement projects is then how do you sustain it? So I'm just wondering if you've thought at all about, you have plans to keep these interventions going now that the project is ended, or make it part of the kind of routine process in the clinic, or along those lines?
Yeah, I think that's a great question. I think that's always something that we should be mindful of when doing these quality improvement projects and considering sustainability. I think there are a few interventions that were more quote unquote permanent, namely the posters that were put up within the clinics in both the waiting rooms of primary care and acute care, as well as the added sort of within a template for well child check. There's a section where it's, did you discuss MyChart with your patient, as you sort of tab through your documentation as like a hard stop. In addition, I think one thing that my pod also really came to appreciate when thinking about this problem was just resident education and orienting the provider to the power of the EMR system and what that can provide us. So for example, setting up your first PCP panel and report and looking at saying, okay, these are all of my patients. These are who is activated. This is who is not. And I think incorporating that as a standard in the resident pod, like orientations at the beginning of the year with the brand new interns, could also be an important step in initiating this each year.
Which is what I'm doing this afternoon, so I will do that.
And I'll add that in addition to orienting the interns, also orienting the faculty to all of these tools and having us use them in our screenings and in our notes and stuff, which we are all now using.
It's on Zoom, and he says, congratulations, this is a spectacular QI project, so well done. And he wants to know what surprised you and what did you not expect?
I'm feeling chatty today. I think one thing that surprised me, or kind of more so gave me pause, was just when we were thinking about ways to incorporate this intervention within the clinic flow. It really gave us even more so appreciation for the clinic staff and all that they do in helping things run. And in terms of thinking about sustainable interventions that should be added into the workflow. You know, we talked a lot about, well, is it fair to ask the nurses to do this or the front desk to do that? And they're already so busy as it is. And so I think being mindful of working in a team and how your project promotes that essentially common goal was something that really stood out to our pod.
So I want to add my congratulations to this because it's really excellent work, and we had the pleasure of hearing the folks at the General present their work. Similarly, around the QI projects from the pods, they had done increasing immunizations and because I think what I see here is a group of people who have been educated to go out and do amazing transformational work, and because you can use these principles and apply them to and I am wondering, seeing some of the really substantive results that you have, what your reflections are about doing something that supports a clinic-wide goal as opposed to doing something that might feel more meaningful to you personally or even within your particular pod, because I know there's been that over the years that comes up, and I see that this work really has sort of broad impact when people are working together, and I'm just wondering what the residents' perspective is on that.
It's a great question, Meg. So the question of whether we should be doing something across all the pods or something individual as a pod that we might have a little more individual investment in. When we were talking about doing this intervention, I think we tried to go back to the roots of why we're doing the QI project. And I think it was Dr. Roth who made a great point that part of this is to make sure that we feel like we can address our own burnout as physicians by making change and making real change. And so part of the reason in Wednesday pod that we decided like, yes, we're on board to do this with the other pods is because we wanted to see change. And if you want to see change, you have to work in a larger group or you often do, and that can be really impactful. So that was part of our decision making. I think this year there's been some feeling like, is MyChart the place that we should be investing our time? Is this the most powerful intervention? Is this the one that's going to kind of help us feel like we've made a really important impact on people's lives? And so I think that's a question. I think it's harder to make a decision about where you land in terms of your intervention when you have a larger group. So I'd be interested to know like how we can continue to sort of like reassess and make sure that we're doing an intervention that's really meaningful to people. But for me, it was really that fact that we could maybe work all together to do like a little impact across a larger patient population. So that was kind of our thought process when we were making our choice.
I'll just say that it's such a beautiful example, this year's project and last year's project, of how when all of our goals align, how much you can really accomplish. And we've had those discussions about kind of the passion behind the projects, and just sort of hearing what you're saying about the staff helping and their commitment to this, and just seeing, I really don't think we would have gotten as far as we had if we hadn't had everybody aligned. So from a clinic perspective, it has been wonderful. And my goal moving forward is to involve the residents more in the choosing of the project, which I know that you kind of are alluding to right now. The last couple of years has sort of been mandated based on clinic needs for good reasons, for good patient care reasons, but I definitely kind of moving forward wanting to discuss more with the resident teams for sure.
Before we go to the next question, if I can just add to that I can sort of hear like, well, is MyChart access really important? And I don't know, and whether it impacts healthcare outcomes, I don't know. But one really important thing that has come out of this project is that we're questioning why we're putting so much emphasis on it, right? We're putting all these energy and resources towards MyChart without actually really asking ourselves, does it help our patients? And I think that's huge. That is a very meaningful contribution, personally.
Hi, I'm a medical student, Marcos. And I really thank you for this kind of QI project. I feel there's a huge need for more focus on Spanish-speaking patients. We know that the population of foreign-born here in the US is like at a 100-year high. And me working with Spanish-speaking patients, having access to MyChart, I think is very important. And I think you addressed this and you highlighted it in your presentation where you said kind of like, you're not sure if just having access to MyChart makes kind of a difference. So I'm wondering like what kind of other counseling do you give the patients in terms of like, this is what you can do in MyChart. You can like look at labs, you can look lab results, you can look at notes, you can look at, or you can just message the clinic, just so that the kid get a better sense of like what they were signing up for, and maybe getting a sense of like, maybe there's gonna be like a big impact on them getting access to.
I think it's such a fabulous question. I would highly encourage you to look at the work of Dr. Courtney Lyles, who is another phenomenal researcher here at UCSF, who has done exactly this. She has run several interventions where she has trained Spanish-speaking patients and other patients how to use MyChart and explored the meaningfulness that they find behind using MyChart and how useful it is to them. So I know some of that work was ongoing last that I checked, but I think she's recently published a paper on it that would be useful that I haven't had a chance to look at myself. But I think the upshot that I've gotten from reading her work is that these interventions are often meaningful to Spanish-speaking families in many ways that we can't anticipate. And it's important for us to listen and learn from those families about the ways in which MyChart is meaningful to them, and not to make assumptions about their underlying savviness with technology, not to make assumptions about what is useful to them, and instead make sure that we're listening to those families and doing that work and that research to figure out what's helpful. And yeah, I think I had one more thing to say, but I forgot about it. We can talk after.
Other last comments or questions? Well, then I want to thank you all very much for this presentation. So another round of applause for. And then I'll speak in the last little plea for the residents and fellows that are here or listening, because Meg and I and others in the education leadership are on our own quality improvement projects to make sure that all of your learning experiences are as good as they can. So if you haven't read your email, or just hit delete or ignore on an email that you got from me yesterday or the week before, or whatever, just filter for my name and please stay engaged with this work and fill out the survey from the GME experience. It really, really helps us very, very much to get through. So thank you, and we'll see you all next week. Thank you.